For the upper extremity D1 flexion starting position, the patient's shoulder will be extended, adducted, and internally rotated. The forearm will be pronated, wrist ulnar deviated, and fingers extended. The patient will begin to flex his fingers, supinate his forearm, and begin shoulder flexion, abduction, and shoulder external rotation. The patient will end up in the position with his fingers fully flexed, wrist radial deviated, and his shoulder abducted across his body, flexed, and externally rotated. The clinician will put their hands on the anterior side of the patient's arms. With their palms facing down, one arm will be above the elbow and the other one will be on the wrist/hand. The clinician will instruct the patient to start with the distal part and move his way up his shoulder, flexing his arms, fingers, and crossing his body. The clinician will switch their hand placement and then instruct the patient to reverse the movement. The patient will start with his shoulder extended, abducted, and internally rotated. His forearm will be pronated and his fingers will be flexed with his hand at the opposite hip. The patient will begin the movement similar to pulling a sword with his shoulder fully flexed, adduction, externally rotated, arms supinated, and fingers fully extended back. The clinician will place their hands over the dorsal ulnar aspect of the patient's hand and on the anterior lateral surface of the patient's arm, just above the elbow. The clinician will instruct the patient to move the distal joint first and then begin to flex his wrist, arm, and shoulder, moving to the opposite hip. The clinician will then ask the patient to reverse the motion that he just performed. The patient's hip will start in an extended, adducted, and internally rotated position. His ankle will be plantar flexed, and his foot will be inverted, and his toes will be flexed. The patient will begin to move his knee towards his chest and his ankle towards the opposite hip. He'll end in the position with hips flexed, adducted, and externally rotated. His ankle will be dorsiflexed with his foot inverted, and his toes will be extended. The clinician will place their hands on the distal anterior medial aspect of the thigh and on the medial aspect of the dorsal surface of the foot. While the clinician is providing resistance, the patient will move at the distal joint and move proximal, pushing his ankle towards his hip. Then the clinician will switch their hand placement and the patient will reverse the movement they just performed. The patient will start with his hip extended, adducted, and externally rotated. His ankle will be plantar flexed and inverted. His toes will be flexed. The patient will begin to bring his knee up to his chest and internally rotating his hip. He'll end in the position with his hips flexed, adducted, and internally rotated. His ankle will be dorsiflexed and everted while his toes are extended. The clinician will be able to provide resistance by putting their hands on the distal anterior lateral thigh and placing on the lateral aspect of the dorsal surface of the foot. The clinician will provide the resistance as the patient starts at the distal joint moving proximal. Once the patient has completed the movement, the clinician will switch his hand placement and have the patient reverse the movement. The D1 and D2 PNF patterns should not be used in the early phases of rehabilitation.